Hi, everyone, and welcome back to Critical Care Echocardiography, especially for the austere provider and the resource-limited medical provider. My name is Harrison Steins, and today we'll be looking at cardiac views and evaluation of pulmonary embolism using some things you may have heard of: McConnell sign, D sign, and TAPSE. You may have heard of these if you've ever trained with like a FAST exam before. But so far, we've looked at the heart in a couple different views: in peristernal long axis, peristernal short axis, and then an apical view, so apical 5, 4, and 2 chamber views. Today, we'll be combining some of these to get an overall evaluation of the heart during a suspected pulmonary embolism. So, for a suspected PE, bedside ultrasound offers life-saving clues: a dilated right ventricle with interventricular septal flattening, known as D sign, or McConnell sign, which is regional right ventricular dysfunction, an akinesis of the lateral right ventricular wall, and hyperkinesis, or just general movement of the apex, can indicate pulmonary embolism, as well as a reduced tricuspid annular plane systolic excursion. So in our last video, we looked at MAPSE, and now we're essentially doing the same thing with the tricuspid valve and taking a measurement at the tricuspid annulus to point as an early marker of right heart strain. So this is important because in settings where CT pulmonary angiography isn't available, say a resource-limited setting, or where your only imaging tool is a portable ultrasound, then these findings may justify some of your clinical decision making after you find them. So it may justify anticoagulation or even thrombolysis based on the clinical context of the patient and bedside ultrasound alone. So these indirect signs of acute RV strain are critical in patients with unexplained hypoxia or syncope, or those that you may suspect a pulmonary embolism. So as far as application of this goes, these findings may justify empiric anticoags or thrombolytics in unstable patients if you don't have a CT, and this is your best source of imaging. And this is especially useful for medics or for deployed teams in settings where high DVT and P risk exists, and you don't have further imaging access or the ability to extricate someone to, say, a tertiary or secondary care center where there is greater access to imaging. Moving on, right ventricle is a great place to start talking about our PE diagnoses. I thought this was a really awesome way of looking at PE as an algorithmic evaluation of the patient as a whole, and then evaluating them with ultrasound. I think classically everyone's taught like D sign and McConnell sign to start thinking about PE. But jumping through this, so if a patient's coming in with their unexplained chest pain, dyspnea, tachycardia, your attendings are pimping you on Wells criteria, PERC criteria, you're suspecting a PE, but CT is not feasible. Either you're in a resource-limited setting, it's not available to you right now, or you're needing to transport them, say like you're in an ambulance or working on flight or something. First thing that we're going to look at is right ventricular dilation. So any of the cardiac views, if you're seeing that the right ventricle is greater than that ratio of 1/3 to 2/3 right ventricle to left ventricle, start to become suspicious. If you see the septum start to flatten, this is called the D sign. It's mostly seen in this pulmonary embolism, and it is highly specific for it. Next, we start talking about McConnell sign, which we'll talk about a little bit next here. Then, if you're still unsure, you can evaluate the heart with TAPSE, which we'll talk a little bit about. Again, that's tricuspid annular plane systolic excursion. So it's a very, very sensitive, as opposed to a specific signal for acute pulmonary embolism. And then finally, tricuspid valve regurgitation, so seen in that apical 4-chamber view. Again, all of these are if this is your resource and maybe you don't have a CT there, or you just have ultrasound at the bedside and you'd like to get more confirmation of something before going to CT and additional intervention. So McConnell sign. So it's defined as right ventricular free wall akinesia, so it's the lack of movement with sparing of the apex. They talk about it as the trampoline sign, so you end up seeing a trampoline bouncing up and down here where you have this right ventricle lacking in motion, so that akinesia and trampoline up there. It's not sensitive, but there was a small study that said that it was specific for acute PE, and it's a very distinct finding. So if you see this on one of your patients with shortness of breath, start to think PE. Moving on, D sign. This is that bowing or septal flattening in the peristernal short axis. It's right ventricular overload causing a shift in the septum toward the left side of the heart. If you've learned this in, say, your FAST, your rush exam, and you want a little bit more, I thought the eccentricity index described by Ryan et al. Was really interesting. So it's an echo measurement of the left ventricle that can actually quantify the amount of right ventricular strain and overload affecting the left ventricle. So it's calculated by taking two measurements at the left ventricular cavity. So it's a perpendicular and a parallel measurement, and then you start to compare them. And based on the amount of pressure overload, you'll get this ratio of like the parallel to the perpendicular measurements as less than or equal to or greater 1. So moving on to TAPSE, that's our tricuspid annular plane systolic excursion. This was the most sensitive method of determining if someone had a PE outside of obviously the CT. But so it's a measurement, distance measurement from the minimum to the maximum excursion, so systole to diastole of the tricuspid valve. So we're aligning our M mode cursor parallel to the motion of the tricuspid valve annulus. And then that annulus should be moving upward toward the apex during systole. And remember, when we're in an apical 4-chamber view where the ventricular and atrial septum are straight up and down, we're identifying the maximum systolic and diastolic excursions of that annulus motion, and then measuring leading edge to leading edge. Once we've found that with M mode, we can place both of our cursors on it to measure the systolic excursion to the diastolic excursion, and then take that value. An abnormality should be under 17 millimeters. Remember that's showing that like there's decreased excursion or decreased movement of that tricuspid valve, which is an indicator of poor right ventricular function. This is an awesome video from the Echo lady who has really great videos on both MAPSE and TAPSE, kind of walking through exactly how to take the measurements. And here's a quick pocket chart on how to do the TAPSE. So apical 4-chamber, M mode, measure tricuspid excursion with your risk factors. So TAPSE is important. A couple studies have shown that it's an independent predictor of increased risk for 30-day mortality in patients with acute PE. It's also predictive for poorer perioperative outcomes.